The Nebraska Cancer Research Center, in partnership with Bryan Health, Nebraska Hematology Oncology, St. Elizabeth Regional Medical Center, and Southeast Nebraska Cancer Center presents Lincoln's Conversations About Clinical Trials. Hello, and welcome to Lincoln's Conversations on Clinical Trials. Today we're going to be talking about surgical variations during clinical trials, and we've got two wonderful guests, physicians in different specialties, who are going to be speaking with us today. I'm Carol Ott Schacht with Strategic Marketing, Communications, and Public Relations, spokesperson for the Nebraska Cancer Research Center, a clinical trial participant, and a cancer survivor. Thank you so much for being with us today. And our guests are with us, and they are Dr. Alan Berg, who's an oncologist with Southeast Nebraska Cancer Center. He's also a clinical investigator for clinical trials. Dr. Berg, well, we're delighted to have you. Thank you very much. And we have Dr. Carolyn Cody. Carolyn serves on our advisory committee. She is a surgeon and serves in a number of different capacities related to clinical trials. She is also a vice president of medical affairs at Bryan Hospital, Bryan Health. We're delighted to have you with us today, Carolyn. Thank you so much.
Thank you very much for asking me.
Well, today we're going to be talking about clinical trials, and so I thought first, why don't I share just a little bit about what clinical trials are. And I think it's important just to remind our viewers briefly that a clinical trial essentially is a study, a scientific study that's looking at perhaps some kind of prevention. It might be some kind of treatment or some way of controlling cancer. These are studies that are done in hospitals, in clinics, anywhere where cancer might be treated. And they're for a variety of different types of cancers. And at Nebraska Cancer Research Center, we do, I think, close to 40 different clinical trials and have a number of different cancers that we're addressing. Now, today, we're going to begin our conversation with Dr. Berg and talk a little bit about sort of when someone is diagnosed with cancer, with whom should they be consulting and when? Because I know that there have been some concerns about waiting to see the oncologist perhaps last on their journey. And what might be some of your thoughts that you would share with us about patients that perhaps you wish had consulted with an oncologist prior to treatment?
Well, I think it's never a bad idea to see an oncologist early on. We might not necessarily change anything. I think a lot of times the biopsies get done either by a surgeon or by a radiologist, and a lot of times they're in the surgeon's offices first, which is certainly appropriate, and most of the surgeons are very good about getting the patients to us for an opinion about whether some other type of treatment might be reasonable first. Every patient that comes into our office is always screened for a clinical trial, and of course we're talking about cancer trials here, so every new patient is screened for a clinical trial, and we try to screen every person who progresses in their disease process for a clinical trial as well. So there's a lot of situations where surgery might be appropriate, but it might be appropriate after chemotherapy and radiation as opposed to the other way around. And so most of the time that's a well-known sequence. It doesn't always fit a clinical trial, but it might fit standard of care. So it's also important to remember that less than 5% of patients nationwide participate in clinical trials, so it's hard to make good progress with small numbers like that.
And we're trying to increase that number,
Right.
especially right here in Lincoln, Nebraska with the Nebraska Cancer Research Center. Mhm.
Right, and the Cancer Research Center has a long history in Lincoln, dating back to the early 80s for participating in research trials, mostly breast cancer and colon cancer, but much bigger variety now.
And that's wonderful, because I know we're, of course, here in Lincoln seeing a lot of different kinds of cancers, and I know that once people learn about what a clinical trial could do for them in terms of either enhancing or adding other options for them in terms of their, maybe you'd like to speak about that.
Well, it's well known that doctors that participate in this type of research do provide better care, and it's also well known that patients that participate in clinical trials receive better care. So the combination is really better for everybody.
Well, that's interesting, yes.
And it's better to do it in our community where you can get the same therapy that you'd get at Mayo Clinic if you went there for an opinion. They'd offer you the same trial, and so it's nice to know that you're getting basically the same therapy.
Well, and it's interesting, Dr. Berg, that you mention that they're going to be getting the same kind of treatment and therapy that they would be getting at perhaps a major cancer center. But also the fact that if they don't participate in a clinical trial, although they will have access to treatments, that it will not necessarily be the latest, the most cutting edge, if you will. And then you mentioned that they would get better care. Talk about that a little bit more, what you might mean by that.
Well, participating in a clinical trial, you're getting the most up-to-date therapy. You're also getting a set schedule with little variation, so you get the right therapy on schedule at the right dosage. You get the right follow-up. You get close follow-up. Everything is standardized, so there's very room for mistakes and errors. And these trials are written by the leading experts around the country. They're not. It's not a local thing that we just made up out of the blue. It's nationwide standard of care.
And Dr. Berg, I think that's very important for our viewers to know. I think a lot of people really aren't aware that these standards of care are the same wherever they might be seeking their treatment, or in particular now as we're speaking about clinical trials. So that's really exciting. What about, and perhaps you're speaking to this, the attention given to patients? How might that be different when they're on a trial versus not being on a trial?
Well, the data managers, for one, are very good. And so they have to keep track of all the data, and it all has to fit exactly. I mean, we have to follow the program fairly rigidly. And so they keep everything on track. They let us know what's necessary. They let us know if doses need to be adjusted, follow the toxicities. They submit all the data to the central study group. So there's quite a bit that's involved.
It sounds like there's a lot of documentation, a lot of time and attention given to making sure that you've got them on the right protocols at the right time, and that is perhaps maybe more attentive, if you will.
Well, when they analyze the data and they publish the information later, everything has to be the same for every patient in the trial. There you can't be doing something different for somebody and not the other if they're on a trial. Everybody has to be the same. The eligibility criteria to get into the study are the same. So everybody is pretty much equivalent across the board. That's the only way you can you know, publish data with results.
Well, it sounds like the word perhaps rigor. There's a lot of rigor around. There's just that need to make sure that you have that consistency. Otherwise, it wouldn't be effective. Yeah, the results wouldn't
be reliable.
Wouldn't be reliable. Wouldn't mean anything. Right. So that's really helpful. So that when someone is on a clinical trial, there is that higher level of attention given to sort of everything, every step of the way, and that there is that consistency. And I think that's important for people who are facing cancer to know. So thank you for sharing that with us. Thanks very much. Well, Dr. Cody, we wanted to visit with you today about the surgeon's perspective. Dr. Berg is an oncologist, and so his specialty looks at certain elements of that clinical trial and that cancer journey that a patient is on. And you're a surgeon, so your perspective and what you do is different. So we'd love for you to share with us, from a surgeon's perspective, what are some of the surgical options that, that patients can be considering?
Depending on the kind of cancer that the patient has, there are quite a few surgical options. Now, I think one of the roles of the surgeon in conjunction with the oncologist is to make sure that the surgery that we are doing is consistent with what's required for the trial. That's one of the reasons to have that patient see the oncologist. As a surgeon, no, I can't keep track of each requirement for each kind of study that requires perhaps a larger surgery or a smaller surgery, or might exclude a person who has had a surgery that I might otherwise think is perfectly fine. I want to know that, as does the patient prior to the trial. Now, what we have for options today in surgery are different ways of doing the surgery that in the past has been maybe viewed as major surgery, something that takes as long to recover from, perhaps as treating the disease. So what we would like to do is have a patient have less time in the hospital, more ability to get out and feel normal again. If we're talking about, it is a lung cancer, the VATS procedure, which is visually assisted thoracoscopic surgery. In other words, we put make a small incision and put a small TV camera into the incision, and we can look at the lung, we can look at the vascular and the bronchial structure. All right, where do you need to operate? The very small cancers can even be marked ahead of time by the radiologist, so that we can do a lobectomy, a relatively minor chest surgery, if any of them can be called that. But the patient is well, they're up and really able to function in a few days as opposed to a few weeks.
That's really important for patients to know too, that now that and that would be a type of treatment that you would be using. Would it be for diagnosis, or would it be for removal? What are you actually doing when you're doing the lobectomy?
What we're doing with a lobectomy, let's say that is either diagnosis or treatment. Technically, we're removing a small portion of lung and the attached bronchial or bronchus that supplies that. The, let's say, VATS procedure can be used for that diagnosis. It can be used for treatment. It can be used actually to survey the results of treatment. So that it has a lot of versatility. And as I say, that element of getting back to normal is tremendously important.
Well, and the fact that it just seems less invasive, as you said, yeah, if any of them could be considered lesser, certainly if you're taking an entire lung, that would be pretty traumatic and pretty difficult.
Yeah, that's not only traumatic and difficult, but has really very serious consequences for function. Someone who has relatively maybe poor lung function to start with, then undergoes a lung resection, a major lung resection, is now way behind in what they can do. And they're also going to need to recover with much more time and effort than if we'd been able to do a lesser procedure.
Oh, that's really exciting. Wow, from a patient's perspective, and I know for a lot of our viewers out there, because we do have a lot of different types of lung cancers in this community, to know that we have that type of procedure is really exciting.
But I want to know from you whether that's acceptable for your study.
Well, from our standpoint, it's helpful because for the lung cancer trials, for treatment after surgery, you have to have the proper surgery done. And so we try to relay that information to the surgeons that they have to sample a certain number of lymph nodes in certain locations, because we have to have that.
And so that would be something that would be driven by the protocol for the clinical trial?
Well, most of the thoracic surgeons would probably do that, but not always. But if we think somebody's a good candidate for a clinical trial, we'd like to make sure. So the data managers, you know, we would send that section of the protocol that for the surgical requirements to the surgeon, so they knew that ahead of time.
Oh, excellent.
So getting a little bit away from breast cancer and lung cancer, the one other trial we have some brain tumor trials, same thing. If the neurosurgeons place a wafer, a chemotherapy wafer in the tumor bed, they're not eligible for our trials. And so we have to, you know, that would eliminate people from available trials.
And that's really interesting to think about too, and I think really important for people considering a clinical trial. What are those questions that they need to ask to know, and what would you recommend?
Well, sometimes you aren't going to know that ahead of time because they go into surgery sometimes not knowing what they have. So it's hard to know if they're going to be eligible for a trial or not. So it doesn't always work.
No, it doesn't. It sounds like a conversation between the oncologist and then the brain surgeon, the neurosurgeon, is important. Do we have those dialogues going on?
Yes, and we try, when we open a new trial, we try to send that information to the appropriate specialists.
Excellent.
You know, if a urologist, if it's a urology type trial, or, you know, we try to get that information to those people ahead of time.
Excellent.
Or let them know that it's there.
And that way then they know that they do have that option. Although some people will choose to go with that and to have that inserted, and that's their choice. And I think that's the other part of this discussion, is that even if someone joins a clinical trial, or if they're considering it, it's always about their choice, an informed choice.
Most trials, the phase 3 trials, most of those trials are not going to be inferior to what you would get anyway. So even if it's randomized to do different treatments, people, you know, have a hard time being randomized. You get this, you're going to get this. But what you get is not going to be inferior to standard treatment.
And I think
you couldn't morally have a study where you thought you might be giving somebody inferior treatment.
Thank you, Dr. Berg. And that's something that our viewers need to know as well, that always that ethical piece is taken into consideration with the clinical trial. There is never a time when someone is put on something that something is knowingly removed from someone that you know could treat them. And I think there's that ethics piece that is extremely important in clinical trials.
There's a lot of safety issues built into all of these trials.
Thank you. Dr. Cody, are there other surgical variations that you might like to share with us that might join in a conversation about clinical trials?
Well, a great deal of the work that I do is with breast cancer, and I can probably speak for far longer than you actually want to hear about that. But breast cancer treatment has certainly evolved from in the surgical management, from no choice but a mastectomy, which was disfiguring, a long procedure, and involved taking a fair number of lymph nodes under the arm, leading to arm swelling and most of the discomfort, to a procedure now with a partial mastectomy, where we will take the abnormality in the breast plus some normal tissue that's around it and sample the lymph nodes. The sentinel lymph node procedure has all but eliminated the problems associated with taking lymph nodes out from under the arm. And that's 1 or 2 lymph nodes that are identified ahead of time, so that a surgery for a woman now with breast cancer comes out with a woman who not only can look very normal, because we're fairly conservative about who can have a very good partial mastectomy, and who doesn't have problems under the arm. My patients in general come in, have their surgery, and they go home the next day, the next morning, really feeling like a normal person.
That's wonderful.
And I do remember earlier, or in some cases that I've done the surgery, a mastectomy is longer. It really is it's an emotional journey too for the patient, in the way that a partial mastectomy usually is not.
And having been on that journey myself, I can speak from the experience, and it is scary, and you're worried about a lot of things that you might not necessarily worry about with another type of cancer. So I think that's really important for our viewers today. There's such a high incidence of breast cancer today. When I was diagnosed 4 years ago, I'm in a PEO group, which is a philanthropic and educational organization for women. 4 of us were diagnosed in 1 year. And what's interesting is that we were all different ages. We had a 5th person who was diagnosed with another type of cancer, but in one group of regular participants, we have about 50 in our group, but 25 regular participants, to have 4 that were diagnosed with breast cancer, we thought was particularly high. Perhaps higher. I think it's 1 in 8 women.
About that.
About that.
1 in 9. It's not that high because people have other problems, but
right, and that affects it as well. But I'm so glad that you spoke to that. Dr. Cody, would you imagine that perhaps the new surgeries that you have, those variations that you have now that are considerably different and safer and seem to cause less side effects that you have with this partial mastectomy you're talking about, were there previous trials that women were on that contributed to the advancement of knowledge that we had that then are, changing those protocols?
I think for breast cancer surgery, the trials were really done in Italy. And the Milan study is really
interesting.
The milestone for partial mastectomy.
Excellent. That's wonderful to know.
The role of radiation therapy was really made clear then at those studies. But they were imported here, and now that's become, I think, the standard of treatment, to have the partial mastectomy sentinel lymph node procedure. And most of the breast cancer trials reflect that. They may vary in how many lymph nodes are required to enter a trial, but we really can offer a great deal in the trials that is consistent with the minimum surgery for any woman.
It's so exciting to know that we have these options today, and you've both talked about them and how they influence the individual patient that's going through that journey, and then also how that influences the choices that they have to make and the options that they have before them, and whether or not they would be able to participate in a clinical trial. I appreciate so much the time you have given to us today and all the expertise that you share, the concern and the care and the compassion that you have for your patients that are on these really challenging journeys. And I'm so grateful for both of you to be with us today and for your practices here in Lincoln. Thank you.
Thank you.
Well, this concludes our conversation today about surgical variations with clinical trials. We've had a very interesting conversation with Dr. Alan Berg, an oncologist, and with Dr. Carol Ott Cody, a surgeon here in Lincoln. And we are just so grateful that they could be here again with us today. One of the things that we hope this conversation has helped you to think about as a viewer today is that if you are faced with cancer or a loved one is faced with cancer, that you will consider participating in a clinical trial. And for more information about clinical trials, would like to make sure that you are calling, we've got our number up on the screen, 402-483-2827. What's exciting about that is that you can not only perhaps have a different opportunity or options presented to you for your treatment and your cancer care, and perhaps more attention and better care even given to you as a result of being on the trial. But you are helping others as well, and we know that for many people that part is extremely important. So for the Nebraska Cancer Research Center, for our advisory board, and for our community partners, Southeast Nebraska Cancer Center, Nebraska Hematology Oncology, Bryan Health, and St. Elizabeth Medical Center. This is Carol Ott Schacht, and I thank you for being with us today.
Home is where you celebrate life.
Home is where you spend time with loved ones. Home is where you cheer for the Huskers. And when you're diagnosed with cancer, home is where you want to be. The Nebraska Cancer Research Center offers hope right here at home in Lincoln. Ask your doctor about participating in cancer research. The Nebraska Cancer Research Center. There's no place like home for clinical trials.